So Jackie, you're good to go whenever you're ready.
Okay, I didn't see it pop up, so sorry for the delay. All right, well, good morning. Thank you guys for being on time for September's case reviews. We've got a good couple cases. There were a few cases even over the weekend that were contenders to be put in here, but for a matter of getting this done timely, they'll be for next month. As always, this information is confidential and privileged. It's protected with the HIPAA Act, and that any use, distribution, or copying of this information is strictly prohibited. And moving on to case 1, I just want to, before I move forward, I'm just going to make sure I'm logged in to see the chat as well. Nope. I'll just leave that to Mark then. All right, so for the first case, it's a 78-year-old male who woke up complaining of chest pain and shortness of breath. PPE usage documented included a HEPA mask and gloves. The first set of vital signs were obtained 2 minutes after patient arrival or patient contact. And I believe this was in regards to the transporting agency AMR, so the times are based off of their documentation. So 2 minutes upon arrival, heart rate was 80, blood pressure was 99/64, respiratory rate 19, GCS of 15, SATs of 93%, and he weighed approximately 91 kilos. They noted that he was awake, his airway was open and protecting, but he was very pale, very diaphoretic, and warm to touch, no signs of active bleeding. And his past medical history presented to EMS was that he had a history of hypotension, bradycardia, asthma, and acid reflux. He woke with chest pain. He told his wife that he needed help. She called 911 and came back to find him unresponsive. She started CPR, and prior to EMS arrival, he regained consciousness. Prior to transporting agency's arrival, an IV was established. This was around 1:20 in the morning, or this was 1:20 in the morning. He was found supine in bed, complaining of chest pain and shortness of breath. The first set of vital signs I've already reported to you guys, and that they also documented pain score, which is not a common thing, so thank you for documenting that. They tried to get a 12 lead on him, but they remarked that it was markedly difficult because of how diaphoretic he was. So that was at 4 minutes after patient contact. They did get a blood glucose, which was 121. In addition, in their documentation, they said that the first EKG was obtained, to my recollection, by the fire agency, and it was reported to be normal. I wasn't able to review that, so I don't know. But presumably it was normal. They moved him by TARP because of how bad he looked, and they applied AED pads to him. They placed him on nasal cannula oxygen, and they documented end tidal CO2 of 39. A second IV was placed. He was given 1 liter throughout his course through that IV. And then the first successful 12 lead by the transporting agency was obtained 17 minutes after patient contact. He received full dose aspirin, and this is the 12 lead. So looking at this, he's narrow complex, a little bit of a artifact, but it appears to be sinus, specifically if you're looking at least the second complex in lead 2. He looks like he's got ST elevation. When we're looking at this, I'm saying that his most significant ST elevation appears to be in his inferior, but he also seems to have ST elevation potentially in 1 in ABL. He's got reciprocal changes in his anterior leads. They activate this as a STEMI alert and leave the scene 20 minutes after patient contact. As they get into Pulsera, they're notified that the cath lab is unavailable, and using our protocol, they made the decision to go to a manual. Because of how poorly he looked, they placed him on Lucas prophylactically. He hasn't arrested in EMS's eyes at this point, just reported arrest prior to arrival with short resuscitation. They repeat his 12 lead again at 21 minutes. And now what you're seeing is a markedly worse ST segment in the inferior leads, looking more tombstone. And then he looks like he's got some ST elevation in his lateral anterior, but his lateral leads in the V4, V5, V6 range. And then some marked ST depression in ABR. So they get another set of vital signs. He's got a heart rate now of 74, not too different than previous, but his blood pressure is 90 by palp. He still has a GCS of 15. He's breathing 15 times a minute, and his SpO2 is 99% on that supplemental oxygen. They get another 12 lead. They give him 50 micrograms of fentanyl, and they get another set of vital signs. His end tidal CO2 is 31. His pain's a little bit better after the pain control. And the 212 leads come up together. So that's why I waited to move over. So if you're comparing from the previous one, his ST segments are actually a little bit improved compared to the previous one, but still markedly elevated. And then that second EKG starting to see profound bradycardia. From that, he becomes more bradycardic and he arrests. It's documented that they didn't have initial rhythm of his arrest, but I assume that this is probably like a PEA arrest, and we just didn't put that in our procedure, so don't forget to do that. They document that they couldn't place an eye-gel because he was clenched, and they performed CPR with the Lucas, ventilate him with a bag valve mask, and he achieves ROSC shortly thereafter. They don't document that they give him any meds, so probably within the next pulse check, he gets ROSC. They note, though, he's profoundly bradycardic, rate of 20. They can't get a blood pressure with that. His respirators of 18, his GCS is 14. So they attempt to pace him at 70 milliamps at a rate of 80. They state that they were unsuccessful with mechanical capture, but as you can see in this EKG, if I can get there, it appears that they are getting electrical capture, just not mechanical, or he was so profoundly hypotensive we couldn't tell. They document that they started an epi drip, but they were unable to start it before they arrived to the ambulance bay, so they elected to transport him over to the hospital. So crazy case, very sick, a lot going on. I thought that overall, and I think that that this sentiment is shared by Dr. Mock, that these guys did a really great job on a complex, difficult patient with a longer than anticipated transport, as the cath lab at Peace Health was unavailable. So in reviewing this case, I thought the things that we really did great here is that we got early set of vital signs. We didn't walk this patient. We recognized how critically ill they were, and that even something that seemed so benign to walk them could increase the cardiac load or the cardiac O2 consumption. So we did our own moving of this patient, who wasn't a little person. We placed them on supplemental oxygen because the stats were 93%, and per our protocol, if the stats are less than 94% in a ACS or STEMI patient, we should be getting them supplemental oxygen, but we should be making our goal around 94, 95%. They documented that the reason why they didn't get in a 12 lead earlier is because of how difficult it was to get contact with his skin with the pads or the leads. Serial 12 leads were obtained instead of just stating that he's a STEMI and we're not going to get any additional ones. He got full dose aspirin. They held nitro appropriately for concern for worsening hypotension. And they did a great job preparing this patient. I'm sure trying to put a Lucas on a wake patient who's an extremis is probably confusing to them, but once explaining why it's on, it's probably very sobering to realize that we're getting ready to potentially do CPR on you. And then notifying the hospital appropriately early to let them know what they're expecting, especially since they can start activating the cath lab from the time that we notify in the field, but additionally to let us, the hospital can let the EMS agency know if they have the capacity to take that patient earlier than later. So, and then the next steps, pacing this patient, getting ready to start an epi drip. Here some areas, there were a few things that we could potentially do differently in the future with a case similar to this, is with inferior MIs to get a V34 and a V4R. rhythm or leads. And then don't forget to document what the initial rhythm is under the cardiac arrest procedure, so that when we look at this information, we have an idea of how many patients had this type of rhythm when they arrested when we're looking at our data. And then scene time goals of 20 minutes. With AMR, their time from patient contact to transport was 20 minutes, and that's 20 minutes for STEMIs. But if we look at the fire agency's first arriving scene time, we were 25 minutes before we left the scene. Also, the additional component to that is that it wasn't recognized that the patient had a STEMI there was a 12 lead obtained early on. So if we don't think that they're a STEMI, then as soon as we identify the patient is having a ST elevation MI, moving forward to get off scene. And in this case, if I was reviewing this case for KPIs, I would pass this as the original 12 lead didn't show. Once I saw the original 12 lead, I would pass this as this one didn't show a STEMI initially. Anybody else on this call have any questions, concerns, kudos for these crews on their pre-hospital care? Anybody on this call took care of this patient? Wanted to add anything about their experiences? All right. So moving forward, shortly after his arrival into the emergency room, he went into cardiac arrest. They resuscitated him for 6 minutes. They were able to get ROSC, and he was emergently taken to the cath lab. In the cath lab, he had a transvenous temporary pacemaker placed. They noted that he had 2 lesions, one to his LAD ostial 70% stenosis, and then the second one to distal RCA with 95% stenosis and a thrombus associated with it. They put in a drug-eluting stent to the distal RCA, and they put in a balloon pump because he was also in cardiogenic shock. They transferred him to the ICU. They exchanged that balloon pump for an Impella CP. I don't know what the CP stands for. I did a little search, but I didn't come up with an answer. Anyone else, feel free to state what CP stands for. He was extubated on the 7th of September, and during his hospitalization, he had paroxysmal AFib, and he also had a wound, which I think was secondary to pressor extravasation from an IV infiltration. And he was discharged home to cardiac rehab, or home/cardiac rehab on the 12th. So I thought this was a great case of one, just showing EMS care being really stellar. And then another thing is because currently we've been having some experiences in our county with limited resources, not just because of what we have capable, but also because of having limitation in our physician availability. So what I guess I'm trying to say is that at Peace Health, at any given time of day, the max amount of cath lab tables we have are 2. And that when we notify through Pulsera that we have a suspected STEMI alert, I don't think that we're at this point, FYI, in regards to the cath lab team being notified immediately based off of our Pulsera communication, but that's in the future, near future, I think. But anyways, that we'll be able to, Peace Health will be able to tell EMS if they have availability with an open table in the cath lab. We can't say we will not accept a patient to Peace Health, but we can let you know if there's no cath labs available at the time that you're trying to bring a patient. And then we ask that you follow our Clark County protocols, which come up in the next slide. Maybe like a little bit of a precursor to next month's case reviews is that I think that it would be best if you have a patient that you suspect has an acute coronary syndrome, you're really worried about them, but they don't necessarily meet our county protocols on STEMI activation. I would say instead of putting it into Pulsera as a STEMI activation because you want the hospital to be aware of your concern for the patient, I would suggest that you put into Pulsera that you have a chest pain patient, suspected ACS, and ask that the doctor looks at this 12 lead. As it is now, it's up to the charge nurse. If you send a chest pain patient through Pulsera and you don't indicate that you want the charge nurse to show the doc your 12 lead, they sometimes look at your 12 lead and they sometimes don't look at your 12 lead. And so we had a case yesterday that they didn't look at the 12 lead, and I believe that the patient could have been activated in the field as a possible STEMI alert. But the reason why I'm asking that if we don't meet our criteria, instead of just putting them in as a STEMI, is that we may at the, in the hospital side of things, state that this patient doesn't meet our criteria for the hospital for a STEMI activation, and we don't want to divert that patient to another hospital because we think that this patient is a STEMI alert, and we automatically say that we don't have room for that patient. Does that make sense? I don't know whose mic is on.
Yes, clear.
Okay. If you have any questions about that, please feel free to ask me in person at work or reach out to me by email or phone. So follow our protocol. So that goes to our next slides. For our chest pain ACS patients, we treat them with universal precautions. We want our goal SATs to be 94 to 98%, but we're not aiming for 100% because of the potential for oxygen toxicity. But we do want them above 90. We want them at 94%. So this patient was 93%, FYI. Get a 12 lead. Really are aiming for 12 leads within the first 10 minutes of patient contact, specifically if they are having a STEMI. So the sooner you put on a 12 lead, and that's not a 4 lead. We don't even mark your 4 lead as a 12 lead of view because it's not. But get a 12 lead on as quickly as possible as your situation allows, and then get aspirin on as long as they are not contraindicated to give to the patient. So every patient, even in the hospital setting, I ask, are you vomiting or pooping blood? Or are you allergic to aspirin? So that's a good thing to ask, because just remember some of your patients that are having a GI bleed may have some anginal complaints because of how low their hemoglobin is. So just ask. And then if they have any significant liver failure or any other contraindications, you are aiming to monitor their blood pressure closely, in that looking at any evidence of hypotension might be a contraindication to begin giving nitroglycerin. If you have, if you think that you have an inferior MI, don't forget to look for a right-sided MI. And if they are taking any of the phosphodiesterase inhibitors in the last 48 hours, they should not be getting nitroglycerin. We would prefer that we get IV access prior to nitro, but that doesn't necessarily mean it's contraindicated in all aspects. And then fentanyl, remember, is 1 mic per kg. Can be given various ways, and we should not be giving a dose greater than 100. This crew, although this patient was 91 kilos, appropriately reduced the dose of fentanyl to ensure that this patient didn't become even more hemodynamically unstable, but also trying to treat this patient's pain and anxiety. So I think that it was a really smart decision on this crew's part. And if you think that you have a suspected MI, you follow down the STEMI early response protocol. So these are patients that have had chest pain for less than 12 hours. They have ST elevation 1 millimeter or greater, and at least 2 contiguous leads, 2 leads looking at the same portion of the heart. And they don't have a left bundle branch block or a paced rhythm. Notify the emergency room that you're trying to transport the patient to as soon as possible. Treat their symptoms appropriately per our chest pain protocol we just went through, and they should be coming code 3 to a capable hospital for cath lab. Usually that's Peace Health, but if we're not able, because you've looked at HOSCAP or you've gotten the feedback from Pulsera, then they would need to go to the next appropriate, which might be Emmanuel, Providence Portland, Portland Adventist, Kaiser Sunnyside, or OHSU. And if you think that any of these other hospitals are inappropriate, or you're on the borderline of calling this patient as a STEMI or not, contact medical control and they can help you through that. If you are really worried about this patient, and you don't see an EKG finding to confirm your worry, keep on getting a 12 lead every 3 to 5 minutes, but especially when there's a big change in the patient's status, as this might help you identify what's actually going on with them. All right. Any questions about case 1?
Jackie Dustin has his hand up.
Okay, go ahead.
Yeah, this is Dustin, Fire District 3. I was just gonna pass on. I talked to the 2 that responded. It sounds like with case 1, the first couple attempts at 12 lead, they were able to get 12 leads, but they said they were so full of artifact that they didn't bother uploading them. But that's the best information I have as far as the early 12 leads for that case.
I wonder if it'd be better to even upload whatever we have, even if it's poor quality, because when we're looking at reviews, we can at least say this is the information that they had at hand. What
Yep,
does
that
the,
information was passed on to them as let's
Okay.
upload what we have.
Okay, yeah, because then we can be, then, you know, it's even more confirmation that yes, that didn't meet the criteria because the quality of the EKG was so poor and that it wasn't because of a lack of effort. So now, thank you for that perspective. No other questions. We'll move on to case 2. So this is of a 20-year-old female. She was called, we were called to go on her because of a reported overdose, and that upon patient contact, she was leaving the house escorted by her family to the ambulance. This was reported as an ingestion of her home meds. She was complaining of some dizziness. PPE usage was maximum for this patient, and vital signs were obtained shortly upon patient contact. Her heart rate at the time was 109. Her blood pressure is 152/93, respiratory rate of 22, GCS of 15, SpO2 of 99, and her weight was 50 kilos. They noted that she was awake. Her airway was open and protecting. She was pink, warm, and dry. There was no signs of bleeding. She has a history of anxiety, bipolar disorder, and depression, and that she had taken her home prescribed Wellbutrin, reportedly 78 of the immediate release 150 milligrams and 15 of the extended release 300 milligrams, totaling quantity of 1.2 grams or 16,200 milligrams. And this was approximately 30 minutes prior to EMS contact. They documented that the patient was kind of checked out a little bit, uninterested, kind of flat affect, staring off, not really interactive. This was around 3:25 when patient contact was made. So remind you, 30 minutes after she reportedly ingested this. They contacted Poison Control 3 minutes after they made contact with the patient, and Poison Control recommended no activated charcoal. They said to monitor for a hyperadrenergic state, and that make sure to monitor for QTC prolongation or evidence of seizures. At 5 minutes, she continued to be tachycardic. Blood pressure is 139/90, respirators at 20, GCS 15, SATs of 100%. They got another set of vital signs at 9 minutes, largely unchanged. They placed an IV 13 minutes into the call, and they checked a sugar at 16 minutes, which was normal at 161. They initiated transport 19 minutes after contact, and they did repeat vital signs, looks like every 5 to 10 minutes. Noted that her tachycardia seemed to improve a little bit, but for the most part, there wasn't a major change in her vital signs, and they arrived to the hospital at 42 minutes. So in just looking at the pre-hospital care of things, early set of vital signs, serial vital signs, starting an IV, contacting Poison Control, and checking her blood glucose. They did not upload a 12 lead or document a procedure for a 12 lead. So especially with any ingestion, we should be getting a 12 lead. But additionally, as Poison Control had informed them to monitor this closely, They did put in 4 leads, but we really need to be doing 12 leads to make sure that we're being diagnostic in our intervals. So in the emergency room, a 12 lead was obtained. Her QRS was 90 milliseconds, but her QTC was significantly prolonged at 581 milliseconds. She had a seizure. As they were administering Ativan, she stopped seizing, but they went ahead and gave her 2 milligrams of Ativan due to the concern that she'll likely seize again. While in the emergency room, I think that the ICU doctor was down there and that they documented that the patient had another seizure, and due to her large ingestion, they wanted her to be intubated prophylactic for airway control and start her on propofol to decrease the likelihood of continued seizures. In the emergency room, they also contacted poison control. She was admitted to the ICU overnight on her first day. She developed fevers, recurrent seizures, as well as ventricular tachycardia and refractory hypotension to IV fluids or pressors. Her continuous benzo drip was at 4 milligrams of Ativan per hour. She was switched to 15 milligrams of Versed per hour with boluses, still unable to control her seizures. She was on a norepi drip. The cardioversion was attempted for her VTAC, but she was refractory to that. She was also started on a bolus and drip for amiodarone, and she was given bicarb, and as a kind of like a last ditch, they gave her intralipids. She was too hemodynamically unstable at Legacy Salmon Creek, and she was transferred to a manual for consideration for ECMO. What I will say is in the emergency room note, it said that they think that she actually consumed 20,000 milligrams. So not substantially more. Her original per documentation of her ingestion at 16,000 milligrams would be very significant. So presumably even higher volume of ingestion she had. She actually didn't start ECMO. She was able to be extubated on hospital day 7. She was transferred to the psychiatric inpatient on hospital day 19, and she was diagnosed in her discharge from this presentation. And I say this presentation because this happened, I believe, back in February, and I was reviewing this case for this case review, and there's been multiple presentations for psychiatric issues since then, but she was diagnosed with serotonin withdrawal syndrome, shock, respiratory failure, prolonged QTC, seizures, and ventricular tachycardia from this overdose. So I thought this would be a great opportunity to talk a little bit about Wellbutrin. You probably have seen it in various indications, but to talk about how potentially dangerous this medication is. So it's a monocyclic aminoketone. The indications or the reason why it's prescribed are going to be for antidepressant, smoking cessation, or adjunct to weight loss. So the mechanism of action is that it inhibits the reuptake of norepinephrine and dopamine, but it has little effect of serotonin. So it's unlike the other antidepressants that are SSRIs. Concentration peaks at 2 hours for immediate release, and then for extended release at 5 hours. And the half-life in general is 21 hours. These patients, when they take what they consider a lethal overdose. So an overdose generally is more than 450 milligrams. So either her consumption of 16,000 milligrams or 20,000 milligrams is a substantial ingestion. They usually develop tachycardia, drowsiness, lethargy. They are at higher risk of seizure. And of note, the seizures can occur even at therapeutic levels of use of this drug. So just be aware, it's not always about an overdose. They may be irritable, they're agitated, they're having heart palpitations, they could have tremors, hallucinations, or insomnia. Kind of think of it as like a stimulant, as in their presentation and their signs and symptoms. And then in severe cases, there'll be cardiac toxicity. And these severe cases are rare, but we'll see QRS, QTC prolongation, dysrhythmias, and hypotension. The management of Wellbutrin overdoses are largely supportive They recommend charcoal if the patient had ingested this drug within an hour, less than an hour, and then potentially, as long as they have an open airway, they're not too drowsy or somnolent, to protect their airway with charcoal and administration. And then potentially they may be a candidate for whole bowel irrigation, but the data that I found was kind of all over the place on that. These patients have an expected extended observation period before they're medically cleared because of the long half-life and the extended release formulations. Really 12 leads, serial 12 leads, cardiac monitoring, and benzos are the treatment of choice for these patients. And then if they're pretty severe, they may get a lipid emulsion, severely ill. So in regards to our region's protocols, we can't have protocols for every single thing. So we don't necessarily have Wellbutrin overdose. You may kind of think of it as, you could look at like a hyperadrenergic state, knowing if you know a little bit about Wellbutrin now. So you can look at F under our poisoning and overdoses, or you could, let's say you don't know a bunch about it, but you know that it's an antidepressant or it's given for an antidepressant indication. You may fall down to the J category of our protocol for tricyclic antidepressants or Benadryl, but it's not a tricyclic. Best case is going to be supportive and contacting poison control or online medical control early on to help in guiding how to manage these patients. And then just a little section about our pediatric protocol for overdoses, as a reminder to look at that, as we oftentimes just deal with the adult version of our protocol. Any questions or concerns about case 2? Thoughts? From what I could read, this was a substantially large ingestion, and that ingestions of this quantity often led to non-surviving ingestions, but this patient had survived and had a very critical course initially. All right, so moving on to case 3. This is of a 60-year-old male. This was from earlier this year as well. Chief complaint, at least that dispatch was able to share, was that he was sick and altered. EMS had appropriate PPE, HEPA mask, gloves, eye protection. They were able to get a set of vital signs shortly after patient contact, noted to have a heart rate of 90, blood pressure of 147 over 118, respiratory rate of 12, GCS of 15, and he weighed approximately 66 kilos. They noted that he was awake, his airway was open, he was unlabored, but his skin was pale, cool, dry, and there's no signs of bleeding. Apparently, the patient's past history included gout, unknown cardiac disease, atrial fibrillation, hypertension, pacemaker failure, but he had now had a pacemaker, and that he had a history of chronic pain. And the story that was provided to EMS was that this was a gout flare, that he was been sick for the last couple of days, and that his wife had stated that he was especially lethargic today and wasn't acting appropriately. It wasn't documented what that meant about appropriately, so leave that open for interpretation. So this call occurred at 7:38 in the morning. I told you the set of vital signs that they first got. They document at 14 minutes that his SATs are 93%. The patient provided the story of that he had pain all over, he couldn't stand, and he took his friend's meds, which we're not sure what the friend's meds were. Next set of vital signs is that he's more bradycardic now at a rate of 50. His blood pressure is 135 over 103. His respiratory rate 16. He still has a GCS of 15. And at 18 minutes, they get a 12 lead. So this 12 lead, just like quick glance, looks poor, as in not a great baseline, but also lots of change in conduction. So if you kind of, how I look at this 12 lead is I probably would start, because you're thinking, is this VTAC? my eye goes to AVL and AVF as well as V5 and V6. So it looks like this is his underlying rhythm. And it's Y complex, or its QRS is 0.13, so it's likely a bundle branch block. I would say that it's hard to see in where's V1? I don't see V1 here. Like a left bundle branch block. It looks like he's got either ectopy or potentially non-sustained ventricular beats. So is this VTAC non-sustained? But it looks like not a healthy looking heart is how I look at this. This reads as atrial flutter, but if I look at AVF, or if you march out lead 2 when he doesn't have ectopy, it looks like he's got P wave, so I wouldn't call this atrial flutter. Transport was initiated in 19 minutes. 20 minutes, they took another set of vital signs. He is still bradycardic, but now he's hypotensive. Heart rate 57, blood pressure 93/60, respers of 20, and GCS of 15. They established an IV at 21 minutes. They give him 1 milligram of Narcan. I'm not sure. I don't remember the indication, but they gave him 1 milligram of Narcan. And at 26 minutes, they take another set of vital signs. His heart rate is no longer bradycardic, it's 95. His pressure's marginally better at 98/63, and his GCS remains to be 15. They arrived to the hospital at 31 minutes. So the good here, serial vital signs, attainment of a peripheral IB, 12 lead documentation. Room for improvement is that as the patient became hypotensive, IV fluids may be indicated, and maybe when I say trial, maybe not always a leader, because he's got underlying cardiac disease, but you also see this 12 lead that looks concerning for a sick heart. I would probably add here, I'm not really certain, room for improvement is documentation for why Narcan was given. In the emergency room, the patient had complained of intermittent abdominal pain and bilateral lower extremity pain in his leg for 1 week. His previous history showed that he had a poor ejection fraction with at 20%. Normal cardiac function is 45%. His workup, his blood pressure remained to be borderline hypotensive, 97/62. Documented that his toes were very cold to touch. His chest X-ray showed multifocal pneumonia. He was also COVID positive, under vaccinated. His lactate was elevated 3.9, and his brain natriuretic peptide, which is an indicator for possible heart failure, was severely elevated at 1,634. He had a witnessed non-sustained VTAC, and due to concerns for being in cardiogenic shock, he was started on milrinone, which is an agent that is given to increase inotropic effect. The patient was admitted to the ICU. Initially, he seemed to respond to the treatment, but then he started to have a downward decline. He required additional pressors in order to maintain his blood pressure. And he started, despite having pressors, started having worsening renal failure and respiratory failure. Given this information, his family decided to make him comfort care, and he died on hospital day 8. So just wanted to spend a moment to talk to you guys a little bit about cardiogenic shock and what we can do to identify it and to treat it. So cardiogenic shock is a low cardiac output state, and that's because of the problem being the heart or the pump, leading to end organ hypoperfusion and ischemia. The criteria for someone to consider a patient being in cardiogenic shock, at least in the literature, is that their systolic blood pressure is less than 90 for at least 30 minutes. Another indication for a patient having cardiogenic shock is that they need support to maintain their blood pressure, systolic blood pressure above 90, and to maintain their urine output, or that they are hypotensive and have cool extremities. So that kind of stuff, we don't tend to spend that much time with patients greater than 30 minutes. And secondly, we don't really monitor urine output in the pre-hospital setting. So what might be more helpful for us in the pre-hospital setting is to determine is there evidence of hypoperfusion. Hypoperfusion in the acute state will lead to altered mental status changes. So these patients may be lethargic, less responsive, agitated, or their circulatory exams, such as their capillary refill is decreased, or their extremities are cool. So those are patients that may have clues that they are experiencing cardiogenic shock. Cardiogenic shock is different than heart failure because heart failure, our patients are not always hypotensive and altered. They're more fluid overloaded, and we're seeing that they're short of breath, their lower extremities edematous, they're may have a history of it and they're on diuretics or they're complaining of weight gain. So these are a different type of issue than the cardiogenic shock patients are a different type of patient than our heart failure patients in general. So management is going to be our basics, ABCs. If their airway is open, if there's a problem with their breathing, you can trial them on positive pressure ventilation, in our case CPAP, but they may not tolerate it very well. Getting IV access on them, getting them supplemental oxygen if necessary, placing them on the monitor, and getting 12 leads on these patients to try to figure out what the reason why they're in cardiogenic shock. The most common reason a patient's in cardiogenic shock is from a STEMI. So determining if this patient is experiencing a STEMI in addition to their cardiogenic shock. In the hospital setting, we have chest x-rays, we have cardiac ultrasound. So we have a couple other resources allowing us to help differentiate these patients quickly. And that if they're hypotensive, pressors are appropriate. We have norepi and epi, so that's an option. And in the hospital setting is intra-aortic balloon pump, which this image to the right shows. Basically a pump in the proximal part of the aorta that helps with augmenting blood pressure and perfusion of the coronaries. The prognosis of these patients in cardiogenic shock, predominantly patients that are having an ACS or a STEMI incident, is 80% of them wouldn't survive, but there's all other types of reasons for a patient to be in cardiogenic shock, so that's only speaking to STEMI patients. So for our protocols that could guide us in this situation is that if you were astute enough to determine that your patient was in shock and you thought that it was cardiogenic in origin, you'd fall down to the D section of our shock protocol. And it says the follow appropriate dysrhythmia protocol. You're giving either 250 or 500 ml fluid challenges to maintain a systolic blood pressure of at least 100. And then repeat if they continue to have signs of shock and you don't see fluid overload, such as pulmonary edema, not to exceed 1 liter. And then if they're still hypotensive, you can administer norepi, and you have the option for epi, and that you're going to be titrating it closely with their blood pressure. That's just a zoomed in version of that. Anybody have any questions, thoughts, concerns, contributions?
Yeah, I was the doc that saw this patient, and I think the crew was appropriately concerned, and it was a humbling case for me because it was just difficult to sort out what was going on with this guy. And I think one of the things that didn't quite fit is, I mean, his chief complaint wasn't that concerning, like his feet hurt, but but then like when he started showing these objective signs of hypotension, is a case where like the subjective isn't that concerning, but the objective, the hypotension, then especially just the fact that he was so clamped down and cold in the extremities, those were the things that started to point towards the cardiogenic shock.
Definitely a difficult case, I would say, especially because your historian is not very robust in their explanation.
Yeah, I think he was kind of not a very forthcoming guy, and then there's I think a touch altered too.
Thank you for that perspective, Dr. Mott. Anybody else for case 3? All right. on to case 4 then. I personally like case 4 the most, but I think that's because it has potentially a lot of information for EMS. So please pay extra attention. So this is a case of a 70-year-old male who EMS goes to his house and he is naked in bed and covered in coffee ground emesis. EMS, though, was dispatched for cardiac problem or breathing problem. They document that they used a surgical mask, gloves, and eye protection, and that the patient was unresponsive. His airway was open, but he wasn't protecting. His pulse was present. He was pale, clammy, and cold to touch. They document vital signs 5 minutes after patient contact, heart rate of 135, blood pressure 176/102, respiratory rate of 47, GCS of 3, SATs of 93%, end-tidal CO2 of 17, and his weight is 50 kilos. He's got a past medical history of diabetes and stroke, and the story that was provided to them was by his roommate, and his roommate basically said they found him like this. So last known normal unknown, no additional information regarding his preceding complaints, and that they document that the patient's home is of a hoarder's home, so that it was difficult to gain access to this patient because of the quarters that he resided in. This call occurred at 3:45 in the afternoon. As mentioned before, he was naked, covered in coffee ground emesis. They document that he was agonal with a GCS of 7, but he was responsive to pain. I only say it a little like that because all of the vital sign documentation is that he has a GCS of 3. So this is in the narrative. They start ventilating him with a bag valve mask, not on oxygen. At 5 minutes, I reported those vital signs to you guys, and they gave him 500 mLs of fluid through his peripheral IV. At 6 minutes, they check a glucose and it comes back just as high, and they get another end-tidal CO2 of 15. They noted that his pupils were 2 millimeters, and they gave him 0.5 milligrams of Narcan, and they initiate transport 11 minutes after patient contact. They get their first 12 lead at 15 minutes, which has a lot of artifact in it, but it looks narrow, complex, tachycardic, and no, maybe some ST depression, the V5, V6, but it's poor quality, so it's hard to know if that's artifactual, but no obvious ST elevation. And then in particular, we can't really see the T waves. Maybe the best we can see is in V3, but it doesn't appear to be overtly peaked to suggest hyperkalemia. At 16 minutes, another set of vital signs, heart rate of 118, blood pressure of 199/176, respiratory rate of 45, GCS of 3, and they decide to move forward with intubation or RSI. They give him 100 milligrams of ketamine, 75 milligrams of succinylcholine, and then this is the part that I wanted to correct a little bit. So the intubation attempt, they state that the video laryngoscope wasn't working, so I don't know if they actually placed it in the patient's mouth, but remember, even if your scope isn't working, identify that before you place it in the patient's mouth, because passing any blade past the teeth is considered an attempt. So they document that the video laryngoscope wasn't working, so they moved to DL. And the DL was unsuccessful, and they attempted VL, and that was also unsuccessful. And then they moved over to letting the other agency attempt to intubate this patient. So I want to amend 22 minutes with that this was 2 attempts unless the original King Vision was placed in the patient's mouth. So they move him over to iGel, ventilate him, and then the fire department intubates him at 24 minutes, VL 7.0 tube, and they use a bougie. And from what I can gather, I believe that was first pass success. 26 minutes, they get another set of vital signs, heart rate of 116, blood pressure 158/90. Now they're ventilating this patient at 16. His GCS remains 3, his SATs are 98%, and I want to draw particular attention to his end-tidal CO2 is 45, as the previous 2 were substantially lower. So this is what we're doing post-intubation. He, at 28 minutes, gets his first post-intubation sedation pain package. He gets 100 micrograms of fentanyl. Remind you that he's a 50-kilo guy. And at 29 minutes, they arrived to the hospital. So they were unable to do any benzos for this patient prior to his arrival to the hospital. So the good here is that they rapidly identified that they were going to have difficulty in getting this patient assessed and treated in his current situation. So they tarped him out. They did a complete set of vital signs early, and they did serial vital signs throughout this encounter, which is helpful to determine if the care we're doing is helpful or harmful. They got a 12 lead within 10 minutes of arrival, and they checked a blood glucose. As for areas for improvement, I'm not exactly certain that we really should be focusing. Well, I would say I would like that we would spend our energy and our attention on managing what clearly appears to be a DKA patient, and especially because as we're moving towards intubating this patient, even if there was some opioids on him, he's very, very sick, and that I think that we could use our energy to managing his DKA. So I don't think the Narcan would be helpful, and if any way, it could be detrimental if we're trying to post-intubate, sedate this patient. Succinylcholine was used over a paralytic such as rocuronium, which I think, given that this patient was, at least in presentation, a DKA patient, there's a risk for hyperkalemia. And I'll say it here because I don't think I say it in my subsequent slides. The paramedic that responded to this feedback had stated that they didn't know that these patients are at risk of hyperkalemia. So I assume that there's potential other people in the audience that may not recognize this too. So these are patients that are so profoundly dehydrated from high glucose values, metabolic acidosis, that they are going into acute renal failure. And that's why one of the mainstays of treatment besides insulin is IV fluids, IV fluids, IV fluids. So these patients can be in acute renal failure, and that means that their kidneys aren't functioning. They cannot excrete the potassium, and their potassium levels could be substantially high. So succinylcholine, as a potential side effect or a known issue, is that it can increase potassium levels, serum potassium levels. And I think that what I've seen in the past when I've researched this is anywhere from 0.5 to 1 milliequivalent higher, but that could be substantial in these patients. So really avoiding succinylcholine in anybody that might be hyperkalemic and recognizing who that audience is that might be hyperkalemic is key. And then I wrote in here consistency of documentation because it was unclear if 2 attempts versus 3 attempts versus 4 attempts were made. Clearly, though, it appears that from what I reviewed that at least 3 attempts were made for intubation, potentially 4. So don't forget, placing the blade past the teeth is considered an attempt. And our post-intubation ventilation goals, I bring this up because they document that the patient's breathing in the 40s, and then after they intubate, they ventilate them at 16. And I was hopeful that this was maybe an error in documentation. It's just like, kind of, we always document normal respirations after we intervene, but not, I was hoping that it wasn't accurate, but this call demonstrated that there was a lot of conflict about how to ventilate a patient after intubation. So ventilation goals for a patient that is potentially acidotic, and then how do we determine how to ventilate them, and how do we determine our end-tidal CO2 as our goal for ventilation. And then to remember well, I guess a couple things. We changed our protocol this month. So don't forget that post-intubation sedation, the dosing for fentanyl is 1 microgram per kilogram, no more than 100 micrograms. So this patient was 50 kilos, so 100 micrograms of fentanyl is too much for this patient, although it doesn't exceed 100 micrograms, so it should be 1 mic per kg. And then they documented that the ET tube was very deep when they intubated the patient successfully, and that they were going to potentially pull it back, but they stopped because they could hear breath sounds bilaterally. I think that that's great that we can hear breath sounds bilaterally, but ideally having our ET tube in proper depth, especially in these situations where we have limited ability to hear well in the back of the ambulance or the scene. So trying to ensure that your ET tube is not only in the right trachea, but also the right depth. And then consideration of placing a second IV or IO. So in the hospital, the initial set of vital signs documented on this patient was that his heart rate was 63 and his respiratory rate ventilated by hand was 21 from when he arrived. They document that the ET tube was very deep and that as soon as they started to address it, his end-tidal CO2 precipitously dropped. He had marked bradycardia and he went into cardiac arrest. They pulled the tube, reintubated the patient, and continued with CPR or ACLS care. He did 3 rounds of ACLS care. He got 2 of epi and 1 shock for BFib before he was able to regain ROSC. After they got ROSC, they treated him aggressively with IV fluids, started him on insulin drip for DKA, and due to concern for infection, they started him on antibiotics and maintained his pressures with vasopressors or norepi. He had no purposeful activity after ROSC was achieved, so they placed a cooling cath. And his initial labs were notable for glucose of 649, potassium of 5.7, so this is elevated. A CO2 level of 16, his anion gap was elevated. He was in acute renal failure with a creatinine of 3.26, and although he was covered in coffee ground emesis, his hemoglobin was mildly low at 13.9, but he had a substantial elevation in his white blood cell count. Up in the first bullet point, after they got ROSC, they noted that his end-tidal CO2 was 38. So it's hard to say if his end-tidal CO2 was 38 because that was what our post-intubation goals were in the pre-hospital setting, or it was because of the detriment from his cardiac arrest. But that value of 38 is not in line with the goals of his resuscitation. It went with or without a pulse because of his metabolic acidosis. After getting ROSC, they got a 12 lead. And what I want to draw your attention to is that he has ST elevation. You can see in the inferior leads with reciprocal changes in the lateral leads, 1 in AVL and B5, B6. Although he, for all intents and purposes, was having a STEMI because of his critical nature and his likely contributing factor of his DKA, they decided to medically manage him and not take him to the cath lab. And by the time he was transferred to the ICU, his end-tidal CO2 goals were 18 and his respiratory rate was ventilated at 38. So during his hospitalization, he underwent cooling and rewarming. He has no purposeful activity. The sedation has been held. He has no activity. And when I looked at his care last night, on hospital day 6, he's still intubated. He's not producing urine, and he's unresponsive. The cardiology team has signed off in that his prognosis is poor. So I think that there's some learning to be done in regards to intubating patients. Not only do we want to deal with hypoxemia or hypotension before we intubate these patients, we also want to deal with metabolic acidosis, in that we're really trying to maximize these values as best as we can prior to intubating them, but also recognizing that these may be issues after intubation. So being aware and being prepared to manage them. So I'm going to focus here on metabolic acidosis. So what can we do? We should only intubate patients if we absolutely need to when they're in metabolic acidosis. I can tell you in my practice, if I have a DKA patient that is obtunded, this is a no-brainer patient that I'd intubate if they were like any other condition, but these are patients that I know that they may arrest just with the intubation. That's going to be very important to manage their ventilatory status after intubation. So I'm a little bit more willing to watch them closely before going towards intubation. You may want to consider a trial of CPAP with these patients while we work on trying to treat their underlying cause, but that's a little bit more difficult in the pre-hospital setting, as the only options we have is going to be more IV fluids, as we don't have the option to treat their electrolyte problems besides glucose. From what I could find, there was a question to if there's a role for prophylactic sodium bicarb administration. Number one, it's not in our protocol, so we should not be doing that. And number two, the data showed that it's not been proven to be beneficial, and that ultimately, when you give bicarb to a patient, they have to blow it off in CO2. These are patients that are already trying to blow off excess CO2 to try to deal with their acidosis. So now you're asking them to ventilate even faster to blow off enough CO2. So thirdly, if you decide that intubation is absolutely necessary, these patients are actively vomiting, they're not able to ventilate, their SpO2s are low, then you want to get a pre-intubation end-tidal CO2, because that is the goal of what we're aiming for these patients after intubation. So prior to intubation, remind you on this patient, I believe it was 15 and 18 is what we documented for prior, let's see here, 17 and 15. So get a pre-intubation end-tidal CO2. You're going to give them high, not zero, 100% or 15 liters supplemental oxygen for 100% FiO2. You're going to pre-oxygenate these patients to try to deal with any hypoxemia. And you want the most experienced person in your crew to be able to intubate this patient, because we want every opportunity to intubate them on first pass success and also to decrease their apnea time. And that you're starting them, if you feel uncomfortable about ventilating them at 50 times a minute, because that's what they were breathing at before you intubated, then you can start at 30, and then you're looking at your pre-ET tube end-tidal CO2 and gauging that. So in discussion with the medic, it sounded like they were met with conflict about what to do, that we're looking to just get the end-tidal CO2 number right. We're not working to ventilate this patient at a respiratory rate prior to intubation. In general, when they're not in metabolic acidosis, I think that would be fine, but this patient is clearly in metabolic acidosis, DKA, diabetic ketoacidosis, glucose is high, they're breathing fast, their end-tidal CO2 is low. This patient has objectable data in front of you that tells you that this patient is acidotic, and that one, it can be identified in the pre-hospital setting, and two, we're not looking to start off with end-tidal CO2 values in the normal range. We are trying to help this patient become less acidotic by helping them ventilate and blow off that CO2. If we don't do that, then we increase their chances for dysrhythmias and cardiac arrest, and we're not helping them by intubating them and slowing down their respiratory rate and aiming for normal end-tidal CO2 values. It's a lot to talk about in this, and it's really important because this is one subset of patient that you really could be detrimental in your care if you don't recognize, if you're intubating and you're not managing their respiratory status afterwards appropriately. Does anyone have any questions, concerns, clarification? I'm not saying, and I don't want this to come out as that I think this patient had a bad outcome, because I'm saying that I don't think that we did everything we could have appropriately for this patient to improve their chances of the best outcome they could potentially have.
No, I agree. I mean, these are super difficult cases, and this is the definition of the one patient with DKA that needs intubation. But I agree with everything you said about trying to optimize the physiology.
Yeah. You know, and from what I can gather in the correspondence with the medic is that this was discussed on scene, this was discussed after, like immediately hot wash, this was discussed with peers. In the moment, if you are in a situation that you feel like there's plenty of things that you can do hundreds of ways, right? But if you're in a situation that you feel that is absolutely not the best care for this patient in the moment and that you think may be harmful and you can't get a consensus in speaking to amongst, you know, your peers on scene, we recognize this as a difficult case. Call online medical control and get some information, get a physician opinion, not like a professional. You guys are professionals, but get an additional person to help you, because if you want to start an IV on a patient that has a sprained ankle, or you don't want to start an IV, probably it's not going to be detrimental either way. But this is a patient that if you recognize that you would be managing them totally differently and it affects their outcome and you can't get a consensus that you feel comfortable with, contact online medical control. So if there's no other questions about this feedback on this case, we're just going to go through the protocol for our area in regards to glucose issues. So it's under altered mental status and coma. If they're hyperglycemic, check their blood glucose level. If it's high or well above normal, you're going to watch for symptoms of dehydration, vomiting, abdominal pain, altered mental status, and you can try a fluid challenge of 1 liter and maybe consideration of a 2nd liter. And that is what we have for guidance in the hyperglycemic realm. I didn't see anything for DKA. I'm not sure if Dr. Mock or Mark knows that there is anything specific to DKA in our protocol. I just wasn't able to find it looking for DKA, diabetic ketoacidosis, and the only thing I was able to find is under hyperglycemia.
Well, that's the only thing specific to that. We don't have a specific DKA protocol.
Okay. All right,
Gotcha.
well,
I mean, something we handle more in training than in protocol because there's a lot of nuance there.
no, totally. But that's in bringing this clip of our protocol, that's all I could find in clipping in this to present. Anybody want to add any additional to case 4? It's okay if you don't. So in summary, of the 4 cases we brought up here, when notifying the hospital early on if you think that you have something that is critical, that it needs a specific department such as trauma, stroke, STEMI, notifying us early on so we can help in identifying if we can accept that patient no matter which hospital you're calling from or calling for, and remembering that there is a divert protocol. Wellbutrin overdoses are potentially pretty bad. You can have seizures with normal ingestion, but also with overdoses, in that the care is supportive. These patients can get markedly sick, and that cardiogenic shock are patients that can be subtle in our presentation, but looking for hypotension, hypoperfusion, cold extremities, stuff like that, and identifying to potentially consider IV fluid trial bolus, not substantial amounts, but maybe 250 to 500, with the option to start pressors as well. And that when we intubate patients, and I put in the video laryngoscopy that maybe mostly that we have access to, although the UV scopes are out there too now, we need to be really careful about a decision, because it's not about just getting first pass success, it's appropriately ventilating and sedating these patients afterwards. All right. Thank you guys so much for your attention. Thank you for the contributions that were made. Please let us know if there's anything we can do to help clarify or support you guys out there.
Hey, Jackie, before we go, there's just a couple things I wanted to mention real quick.
Yeah.
A lot of our destination protocol changes have, especially with stroke and STEMI, have included verbiage on checking HOSCAP regarding hospital availability. I just
Yes.
wanted to emphasize that. We just received our scheduling for our neurointerventionalist scheduling for October, and there's 7 days throughout the month that don't have coverage. So really important with stroke and STEMI patients to check HOSCAP regarding status.
Absolutely.
And yeah, and then the other thing I wanted to mention real quick, and it's very common, and I know we're getting rid of these devices. Fortunately, they were nice while they lasted. But with the King Visions, the biggest mistake I see I'm not going to say every time, most of the time, is when the scope is manipulated like an ET tube and your hands get above that little purple line. You pop the head off a little bit. I mean, for lack of a better description, but the head gets moved away and the screen goes blank or it goes fuzzy. So just 2 notes to remember, and thanks everyone for coming.
And one more thing I'd add to the divert thing, and for anybody who doesn't recognize what the stroke divert situation implies to us in the pre-hospital setting, is that when our neurointerventionalists are not available because we don't have staffing for them, then these are for only a subset of patients. These are for our large vessel occlusions or our patients with a high LAM score 4 or greater. So it's important that not only do we identify our patients as possible stroke alerts, but also knowing what their LAM score is when you put that into Pulsera. That's it.
Rui, thanks everyone for coming. Good cases.
Thank you.
Thanks.